I have no financial disclosures. I hope to spend some time this morning reviewing the science behind pre-exposure prophylaxis and preventing HIV among youth in the United States as well as worldwide, describe barriers that may impact PrEP uptake in this particular population, and as well as reviewing some interventions that can address these gaps as well as some that are on the horizon. First, pre-exposure prophylaxis. What is it? So pre-exposure prophylaxis, as you've heard, is a prevention method taken before sex for adolescents and adults who are HIV negative and at risk for HIV to prevent from becoming infected with HIV. And so there are two forms, the tenofovir disoproxil fumarate or emtricitabine, TDF and FTC, the brand name of Truvada, as well as the tenofovir alafenamide, emtricitabine, with the brand name of Descovy. And so Descovy was approved in 2019 for prevention. It's a smaller sized pill. And I would say that when you look at the two medicines, often a lot of adolescents have a trouble swallowing pills. And so one thing, just to go back for a second, that you might notice is that the tenofovir emtricitabine is a slightly larger pill than the tenofovir or the TAF emtricitabine. And so what you see here is that that's just a smaller size pill than a larger size pill. And actually now the tenofovir emtricitabine is now in generic form. And so it's no longer the blue pill that we've been accustomed to, but actually comes in a white form as well. And so the Descovy was approved based on the Discover trial, which was over almost 5,400 adult cisgender men and transgender women. Individuals that were recruited into the study had 2 or more episodes of condomless sex or sexually transmitted infection, and they were randomized to either the TDF versus the TAF group. And what you see is that in this non-inferiority study that actually TAF had not only, let's go back, few side effects, but also had a lower incident of new HIV infections than the tenofovir TDF form of the medication. So really demonstrating that there was no difference. In fact, maybe there were fewer infections, but because the confidence intervals across one another, that really it was not inferior to the TDF form of the tenofovir. And so we've really been trying to move towards using more of this medication in our clinical settings, not only because of the non-inferiority data, but also because, as I mentioned, the smaller pill size, fewer side effects that were noted in this study, and often a lot of patients describe fewer side effects, fewer GI side effects. And so a lot of youth are actually more likely to be successful on this medication than they are on the TDF form. And when you look at recommendations and approvals, the approval for pre-exposure prophylaxis occurred in 2012, both from the CDC and the FDA. And then in 2015, the WHO and the European Commission in 2016 actually approved PrEP for use to prevent HIV. And in 2018, both the FDA and the European Commission approved PrEP in persons that were 35 kilograms and greater. And so that meant that there was expansion of approval of use, particularly in adolescents that may actually be less than 18 years old. There was not an age-specific limitation on that approval, but it was based on weight. And so that really expanded its use in adolescents as well. Now let's look globally. And so there are global data that exists to actually demonstrate the uptake of PrEP across the world, as shown here. And so as of this year in Q1, there were over 1 million individuals that had received a PrEP prescription, had started on PrEP. And we look at Canadian data, really, only 9,657 initiations had occurred as of Q1 in Canada. So really just starting to increase or start uptake in your regional area. In the United States, it's been estimated that 1 million Americans are substantial risk for HIV. And when you look at this and you break this down by who should be using PrEP, we see that only 100,000 persons are PrEP users. And when you really break it down by age, what you see here shown on the right is that very few, estimated 11% or less, are adolescents or young adults. And there are disparities of PrEP within the United States by race and ethnicity, as shown here. What you see here on the left is the racial breakdown for overall PrEP users, which are predominantly white. And what you see here on the right are broken down by gender, so male versus female. And what you see still is that among male PrEP users, most male PrEP users are white, cisgender males, and followed by Hispanic or Latino, followed by African Americans. And so this is opposite of what we see in the United States as the epidemic, because the epidemic of HIV falls predominantly among African American cisgender men who have sex with other men, as well as transgender women. And so we see that there is really a disproportionate match between PrEP use and risk for HIV. And really further on this chart, we see is really a paucity of PrEP use among female persons overall. When we look at this within adolescents specifically, what we find is that the number of PrEP users, new PrEP users by age, as shown here, that there really continues to be low numbers of new PrEP users for individuals that are younger than 18 years old. And so that's shown in this dark line at the bottom. Subsequently, approximately about anywhere between 18% up to 20% closer in most recent years in the 18 to 24-year-olds, and what you see higher rates of PrEP use among the older individuals. And what these lines really show us is that when you look at the rate of new infections versus the PrEP users, the new PrEP users, in adolescents, the proportion of individuals that are new PrEP users is well below the proportion of or the percentage of new infections. And so we really want the number of users to exceed the number of new infections. We have started to see this in the older adolescent and young adults when we look at sort of this data from Gilead, but still it's not where we want it to be. So who is eligible to take PrEP? When we think about who is eligible to take PrEP, I really try to think of it as simple as possible, breaking it down into really 6 areas. And one might say, if you don't use consistent condoms with all types of sexual activity, then you're at risk for HIV and you're eligible for PrEP. And so if you think of it from that perspective, you really do have a clear guidance on who should be taking PrEP. Now, there are specific guidance whether or not individuals have exposure to certain types of sexually transmitted infections or are having sex with certain partners. However, if you break it down and you just think simply, inconsistent condom use puts you at risk for HIV and you are PrEP eligible. There are certainly other boxes to think about. So if your partner is living with HIV, if you have a history of engaging in sex work, if you have bacterial STIs, particularly if you have gonorrhea, syphilis, we know that those two sexually transmitted infections are associated with very high rates of HIV infection in subsequent years, especially if it is an extragenital site, and that includes chlamydia for men who have sex with other men, injection drug use, or multiple sex partners. So what's the evidence behind PrEP? So the evidence suggests that when taken regularly, pre-exposure prophylaxis is greater than 92% effective against HIV, as much as 99% when there's detectable blood levels of tenofovir with self-report. It's well tolerated with few side effects, but youth do struggle with adherence. And so when looking at the evidence for adolescents specifically, there are three major studies that have been open label studies looking at tenofovir and emtricitabine and the use of tenofovir and emtricitabine to look at prevention of HIV. The first one was 148 healthy, sexually active, HIV uninfected youth that were living in South Africa. They were 15 to 19 years old, predominantly females. They followed these individuals for 12 months. And what you find is that there were very few diagnoses of HIV in the follow-up period. Only one person acquired HIV during the follow-up period. Most of the individuals, so what they did was they actually followed them for a minimum of 3 months, and then they gave them an option to continue in the cohort or stop participating. And 64% of them opted to continue taking PrEP for the 12-month period, and 38%, so not that great number, 38% of the participants had detectable blood levels at the end of the follow-up period. So really what you saw is while 64% opted to continue, there was significant drop off of adherence by the end of the 12-month period. The youth described very few side effects at the end of the follow-up time period. In the US, there have been two specific open label studies in adolescents, ATN 110 and ATN 113. As shown here, the 113 was focused on adolescents that were 15 to 17 years old. These were all individuals that were males at birth and identified having sex with other men. There were no transgender women or transgender men in this study, and they followed these individuals over the course of their time period to see whether or not there was high acceptability, uptake of PrEP, and to follow the incidence of HIV. And what you see here is that there were very few side effects. There were very few adverse reactions. The STI rate actually decreased for the younger population, remained unchanged for the older population. However, there were high rates of seroconversion for the younger population, with 3 seroconversions over the follow-up time frame, with a incident rate of 6.4. This is a little bit higher than what had been found in adult studies where the incident rate is around 3. And so I had the opportunity to work with Sybil Hosek and really looking at tenofovir blood levels to see what happened over time. And so they followed individuals for 48 weeks. And what's defined as suboptimal blood levels is a tenofovir blood level of greater than 700 millimoles per punch, or 4 doses per week. And what you see here is that overall individuals had optimal blood levels up to week 8. And then after that subsequent time, 8 and 12, there were suboptimal blood levels. If you look at it by race, among self-identified white persons, individuals remained in optimal blood levels over the course of the follow-up period, as well as among Latino individuals. Among mixed race individuals, there was suboptimal blood levels noted at 24 week and then also at 48. But what's striking is this dark blue line, which was among African-American self-identified Black participants, where at every time frame there were suboptimal blood levels. And so we had an opportunity to look at this and really found that Black race, self-identified Black race, was associated with suboptimal or subprotected blood levels. But also reporting that you'd been kicked out of your home due to your sexual orientation in the last 12 months, having depressive symptoms, low perceived risk of HIV, mistrust of medications, and fear that others might actually see that you're taking your medications, all contributed to subprotective blood levels. And when we controlled for those other factors, really what remained was Black race and having been displaced out of your home because of your sexual orientation. And so there are some practical challenges when we're thinking about adolescents and PrEP. And so I want to show this clip because I think this sort of gives you a snapshot of what those are.
We are going to get tested for HIV. And I don't want to hear any, I don't need to be tested. You're going, you're going, you're going. We need to know our stats so we can stop spreading this disease.
I want to know. And if we do it together, it'll be less scary. Don't you want to know?
I'm not sure. I guess.
You coming too, right?
Oh, he doesn't need to get tested. He's not running the streets.
I think I do.
But you can't get it from a woman.
Listen, I prefer the ladies, but I'm an equal opportunity lover.
Ain't nothing wrong with that.
Oh, wait, if you're being safe, you shouldn't have anything to worry about, right?
Back in the day, when I was real hard up for cash, I'd let dudes suck my dick.
The symptoms are different with everybody.
So I show that to say that, you know, for every individual, we can't assume why they may or may not want to get tested, right? Or want to take PrEP. There are assumptions about risk. Oh, well, I only have sex with women, or most of my partners are women, so I'm not at risk, or I don't have a lot of partners, so I'm not at risk. And so we have to get away from the framework of labeling individuals. And so we had an opportunity to look at this using data from the PUSH study of almost 500 Black and Latinx transgender women and gay and bisexual cisgender men that were in Baltimore, DC, Philadelphia, and St. Petersburg, Florida. And so these individuals were recruited to complete a baseline survey and HIV testing, and then offered the opportunity to participate in a coach-based intervention and also longitudinal qualitative interviews. This was a high-risk population. It was on the older side. Its mean age was 21, mostly non-Hispanic Black, 14.8% self-identified as Hispanic Black. Most were cisgender males, but 14% were transgender females or gender diverse youth. very high substance use. So 76% of the participants described alcohol and or cannabis use, and 20% described other illicit drug use. So narcotics, methamphetamines, etc. And then 1/4 described unstable housing, and as well as a history of engaging in transactional sex. And 1/4 were living with HIV. And so we invited individuals that were in this longitudinal or the intervention part of the study to participate in longitudinal in-depth interviews. 22 were at-risk youth and 11 were living with HIV, and they had been recently diagnosed with HIV in the last 5 years. And what we heard from them is that their barriers that they described to PrEP were low perceived risk, fear of disclosure, mistrust, and structural barriers. And so I'll share with you some of the quotes that we learned from them. So this low perception of risk was quite common because I was fine living like I was. I didn't think that HIV infection was going to happen like that or was going to happen at all. So this was an individual that was newly diagnosed with HIV that had never been on PrEP. And they actually hadn't been on PrEP because they just didn't perceive themselves to be at risk. And this was a very common theme among individuals that were recently diagnosed with HIV. In fact, only one of our individuals that had been recently diagnosed with HIV had actually been prescribed PrEP. The other common theme that emerged was around fear of disclosure. They were really describing that they were afraid that their parent might know that they were actually a sexual minority in this case. And so that fear of disclosing their sexual orientation also led to a fear of, or a hesitancy to actually use pre-exposure prophylaxis. Quote, I knew that my dad was going to find out. How was I supposed to explain it to him? Like I said, he knows what the medication is for and was going to bring it up, a conversation that I wasn't ready to have. And I didn't even know how he would take it. So I just told myself, I'm not going to be able to get it. And so here's a barrier within families, really being fearful of how the support system is going to respond. And is that going to contribute to outing them or making them more vulnerable? And I heard this from a patient just this week, that they're bisexually identified and they feel like they can't take PrEP because their father has already said, well, that's for gay people. That's not for you. You're straight. Mistrust of medications was also common. Yeah, I showed her, meaning mother, the little pamphlets and stuff, and she was like, yeah, I see everybody you bringing up in here. She was all for it. For her being the same way I am about medicine, she started feeling uneasy about it too. She started asking more and more about it. She was like, do you even know what's going on? I was like, I mean, you're right. That's what she got me thinking. She never told me get off of it, but she got me thinking. And when I was like, yeah, I'm getting too smart for that. That's when I told her, like, yeah, I'd rather just stop. And so here's someone who had actually started the medication, but then the mother was like, oh, do you know what this medicine's for? And then that actually led to discontinuity of medication. And then structural barriers. Just being Black in America, like that's a stress in itself. I feel like when we were talking about PrEP, just being on it, but I've been on PrEP. I know how to take it. I know that I have to take it every day, but it's about, access. It's about my insurance, like all the other like big things that are coming up into play that I can't always access it. And it's not like I don't want to be on the medicine. Like, of course, I want to be on it every day, but a lot of things come up. Like I just got off PrEP for like a week and a half because I wasn't able to go back downtown to get my medicine. But I mean, just everything, honestly. So you hear sort of the overwhelming barriers in this individual's voice of just navigating life and insurance and access and getting the medicine. And it's just real and a lot and heavy. And this gets in the way of taking PrEP. And so we saw that among PUSH participants and a subsample of them, that we asked them about prior PrEP use. And what we found is that there was this huge fall off of the PrEP cascade from a lot of individuals being aware of PrEP, but really only 30% having ever used PrEP. And so there was very high willingness and intention, but really over a quarter drop off of actually using. And what we found was that really having someone striking here right in the middle, this purple line, having someone in your sexual network that had used PrEP successfully was associated with higher awareness, willingness, intention, and use of PrEP in the sample. So how do we address some of these gaps that I've already talked about? So one of the things we tried to do within PUSH was really use a goal setting, MI-based coach model to really center PrEP and HIV care and taking medications for both HIV and also pre-exposure prophylaxis within a goal approach. So really trying to center youth around what are your goals that you want to do, but also how do you get there from a health perspective. Most of the youth described that they had a job or an educational goal, but you also see here that they also describe medical and mental health goals. And so we use mobile enhanced encouragement to actually help youth reach their goals and get on their medications. And we heard from youth that this was really needed, that this helped them to not feel alone, not feel isolated, and feel like they had the support they needed to take their medications. Another approach that has been evaluated and is ongoing right now are long-acting injectables. So the HIV Prevention Trials Network 083 and 084 has looked at long-acting cabotegravir every 8 weeks. And 083 was specific to HIV negative MSM and transgender women. Most were younger than 30 and 12% were transgender women. And only 50 HIV infections occurred within the population. And so really, actually lower rates of infections occurred during the fall period of the cabotegravir than in the tenofovir and emtricitabine as shown here. In 084, over 3,000 women were recruited. 38 infections occurred during the fall time period. And what you see here, again, lower rates of new infection among the cabotegravir arm than among the tenofovir and emtricitabine arm. And so there's been additional studies that have trials that are looking at long-acting injectables in adolescents. So 08301 and 08401, and recruiting 50 individuals in each study. 08301 occurs in Chicago, Boston, Memphis, and Denver, and 08401 in South Africa, Uganda, and Zimbabwe. And so some of the challenge has been that for the women, the recruitment has gone gangbusters, right? And recruitment has already ended. But for the men and transgender women, it's been really hard to recruit. And there have been some particular challenges with recruiting into this study for that reason. William Beckman actually looked at, in a survey of 10,000 men in the US, barriers to long-acting injectable. And what he found was that perceived side effects represent 52% of relative importance, followed by costs. And so, there are other challenges that also need to be addressed, particularly delays in detection of incident infection with long-acting injectables. And so there's a higher delay with the cabotegravir arm than in the tenofovir and emtricitabine arm. So more to come. I think more work is needed in this area, but this is a potential modality that is on the pipeline. I have the pleasure of working with Jose Bermeister and Craig Hendricks and Allison Agu to really look at rectal douching. And I think this is one particular strategy that we need to think about. Craig Hendricks had done the DREAM study of 5,000 racially and ethnically diverse adult men who have sex with men in the United States. Most describe douching prior to receptive anal intercourse. Most express interest in a PrEP delivered douching product. And so we're really looking to see whether or not there's acceptability among adolescents and young adults, and really looking at the pharmacokinetics of tenofovir douching in this population. And then more recently with Dr. Errol Fields, one of my colleagues, we've been trying to leverage the virtual platform. So really trying to use a virtual space to identify individuals that are at risk, and then virtually provide pre-exposure prophylaxis and testing. And within 4 months of launching, we had 500 users that went to the website. Almost 30 sexual and gender minority youth were offered testing. 6 were tested virtually and 8 were offered PrEP. And then all of them were linked to prevention and 4 started on PrEP virtually in that space. So I think this is we're just getting started. This was recently funded by the health department through the ending the HIV epidemic. But I think this is really an opportunity to think about what are some other ways to actually meet youth where they are in these spaces. So looking forward to seeing as we expand this program, how many youth were able to get onto PrEP in the virtual space. And then on-demand PrEP. So there's been some data looking at daily, time-driven, and event-driven PrEP. And so using sort of 2-1-1 versus daily PrEP, and really having some data. There's very limited data, let me say, in adolescents. And most of the data has been done among adults. The iBrigade study demonstrated that it was effective. This one study here demonstrated that there was acceptability for intermittent event-driven PrEP, but there was less coverage of sex acts in that strategy, and that daily PrEP offered higher protected sexual events than intermittent PrEP. And so I think there are a lot of barriers that we need to think about when we're thinking about on-demand PrEP for adolescents. Planning barriers, ability to, from a developmental perspective, have access to the medication, be able to weigh your risk, be able to take the medication and remember to take it in subsequent doses. And so especially when you relay the data from the iBrigade study, where individuals may be having sex frequently versus adolescents who may be having sex intermittently or may go during periods without any sexual activity, I think we have to sort of potentially think about how we modify that approach. I would say just to note that San Francisco had looked at some pharmacy data among individuals that actually did the 2-1-1 strategy, and there were no incident infections. And actually, what they described from this data is that really side effects were infrequent, and there was a lot of adherence with planning in advance. But this was all based on adult data. It has been accepted and released as part of the guidelines, particularly within the WHO for adults, but has not been approved from an FDA perspective. So there are other ongoing studies, particularly, and I put this on here not to have you read all of them, but just so that you know that there are other modalities that are available to adolescents and young adults, and that are being evaluated with regard to preventing HIV. But I'll stop here. I do want to summarize. Overall, pre-exposure prophylaxis is effective. This is our program, the PrEP is for Youth program. I think that there are a number of strategies that are being developed, but we have to think of multimodal strategies, behavioral, biomedical, as well as structural strategies to engage youth, really thinking about how do we incorporate it into other aspects of primary care and care delivery. Particularly focus on provider approaches and how to make it easier for providers to actually implement PrEP in their settings by addressing coexisting barriers and also creating a system that's really youth-centered, sex positive, and very accessible for all youth. With that, I'll end there.